Hello and welcome to the Nestlé Health Science Online Symposium for Westbegan 2020. My name is Karina Venti. I'm an allergy dietitian and associate professor at the University of Colorado and Children's Hospital Colorado in the United States. I will be chairing this session, The Future of Nutritional Strategies for Food Allergy Prevention. I am joined today by two excellent speakers. The first speaker is Dr. Roseanne Meyer. She's a pediatric dietitian and honorary senior lecturer at Imperial College London in the United Kingdom. She also acts as a visiting professor in Leuven, Belgium. The title of her presentation is The Introduction of Solid Foods, where advice on the introduction of complementary feeding and food allergen introduction meets. Our second speaker is Dr. and Professor Karina Venti. Professor Venti is Director of the Sean N. Parker Center for Allergy and Asthma Research at Stanford University School of Medicine. She's also Section Chief of Allergy and Asthma at the Stanford School of Medicine and Endowed Professor under the Medici Family Foundation in Stanford, California. Professor Venti will discuss Around the World in 20 Minutes, Making Sense of Allergy Prevention Guidelines. I will conclude the session discussing It's All About Diversity, Foods, Food Groups and Food Allergens. We have pre-recorded the session for you, but all the presenters are here today live and we will be very happy to answer any questions you may have during the live question and answer session. Thank you for attending.
Thank you very much for that kind introduction. I'm absolutely delighted to have been invited to this Nestlé Symposium, and I'm also extremely honored to be sharing the platform with such eminent speakers. The topic of my part of this presentations today is the introduction of solid foods, where advice on the introduction of complementary feeding and food allergen introduction meets. I know it's a rather lengthy title, but I think it reflects the complexity of this topic well. I'd like to start off by covering my disclosures, which are primarily academic lectures, and I also am on a couple of allergy boards. Now, I know we have people joining from all over the world, and I know also each one of you will have a specific guideline in mind in regards to complementary feeding for the general population and complementary feeding in regards to allergy prevention. I hope you will therefore understand that in this short period of time, it's impossible for me to cover all of them. So I've chosen a couple of selected international guidelines for a general complementary feeding, and similarly also a couple of guidelines for allergy prevention. My presentation today is not about breastfeeding, but I think it's always good to start a presentation on complementary feeding around breastfeeding, just to remind ourselves what the WHO recommends, which is ideally to exclusively breastfeed for 6 months. This is actually a fact where the guidelines are quite clear in regards to the nutritional benefits of breast milk, that's the best source of nutrition. So let's start with looking at when to start complementary foods for the general population. Throughout, I'll be looking at 4 general population guidelines, namely the WHO guidelines, the EFSA Panel on Nutrition guidelines, the American guidelines, and Epigenetics. I think first of all, it would be good to focus just on the dates when they were published. WHO in 2002, so their systematic review actually only includes data until 2001. Then we have the EFSA panel, which is most recent, 2019, Epigenetics 2017, and all of them use very similar methodology in that it's a systematic review. However, there's some slight differences in terms of inclusion and exclusion criteria, which of course I can't cover today. So let's look at the specific language. In regards to the WHO, they recommend starting from 6 months of age. If we're moving to the EFSA panel and the American Academy, both of them recommend around 6 months. Now, around 6 months can be difficult to establish, because does that mean 5.5 months is okay, or is 6.5 months okay? What is interesting with the EFSA panel is they also looked at the impact of iron deficiency. So infants born to mothers with low iron stores, or those with early umbilical cord clamping, small for gestational age, preterm, and those with a very high growth velocity, they have found may benefit from earlier complementary food introduction, solely because of complementary food being a high source of iron if chosen correctly. If we're looking at the EFSA guidelines, they again use a different language, and the ESPGHAN guidelines talk about not introducing before 4 months, but not delaying after 6 months. So a window of opportunity between 4 and 6 months, but they also highlight that introducing before 4 months may increase the risk of allergy. Now let's move on to the allergy prevention specific guidelines. And here I'm going to use again 3 guidelines: the APAPARI guidelines, which is Asia Pacific, the American guidelines, and the IACI guidelines. The IACI guidelines, you will have noticed, were published in 2014. And just that all of you are aware, they're currently being updated, and I understand they are due to be published for public comments within the next month. I think it's important to think about who is at risk when you're looking at these guidelines. The APAPARI guidelines interestingly divides the at-risk population in 2 categories: at risk and at high risk. At risk are those infants who are healthy with a family history of atopy or non-severe eczema, and at high risk, those with severe eczema. The American Academy and the European Academy for Allergy and Clinical Immunology are very similar. Both of them talk about allergic risk being an infant with at least one first-degree parent or sibling with a documented allergic disease. So let's look at the language used specifically here as well. We have here at 6 months at the APAPARI guidelines, so similar to from 6 months like the WHO. Then we have the American Academy, where the primary focus was not delaying beyond 4 to 6 months. And then we have the IACI guidelines talking about after age of 4 months. Now, I've shared with you only 7 guidelines, and between those 7 guidelines, we actually have 5 different wordings. And the wording is from around 6 months, between 4 and 6 months, after 6 months, and not delaying beyond 4 to 6 months. Now, that can be very confusing for healthcare professionals, but it's even more confusing for parents. And I took this from a mommy blog just over the last week, indicating the confusion. This is also reflected in a very nice publications from our colleagues in Australia, where they looked at worldwide guidelines and found a very clear trend to differences and where between the wording used for starting complementary foods. And you can see that those countries from low or lower middle income mostly follow the WHO guidelines, but middle high or high income countries, it's only about 35% of those countries follow the exact wording from WHO. You will see that from those countries, so after, it's more between and around, that you can see the high income or middle income countries are between or around. So there's definitely a difference for whom these guidelines are meant for and who has generated them. Now, this same confusion around when to start complementary foods also exists around when to introduce allergens. I'm presenting here just data from the infant feeding survey from 2010, and I'm sure you can show similar data from the countries that you are representing. According to this data, carers of 8 to 10 month old babies were asked were they avoiding any foods. 45% reported of avoiding at least one food, out of which 41% was peanut, 12% egg, 11% dairy products. Now, this is 2010, but over the last week, I just took this from a Facebook page from a healthcare professional. And this Facebook page, it recommended that these foods possibly could cause problems, and suggest delaying them or until complementary introductions have been well established. And that includes wheat, includes shellfish, includes citrus and egg. So you will see this advice of still delaying foods already out 10 years on from when the survey was done. So let's have a look what the data currently says in regards to general advice. So again, I'm looking at the general population, looking at the WHO, the EFSA, the American Academy, and the Espigen guidelines. The WHO guidelines, the focus was not on allergen prevention. They really looked at variety and particular nutrients. Vitamin A, for example, was highlighted there. When we're looking at the EFSA panel, the American Academy, the Espigen guidelines, all of them meet each other with saying that there's no evidence in delaying allergens. There's slight difference in regards to the age. The EFSA panels does not provide age. They just say no later than the age of introduction of complementary foods. American Academy talks about not beyond 6 months. And again, the Espigen guidelines talk about beyond 4 months reduces that there's a window of opportunity. So no evidence that delaying the introduction of allergens foods beyond 4 months of age. However, there are slight differences here as well. So Espigen brings up the LEAP data, so talks about the high-risk population where it might be beneficial for introducing peanuts earlier. And the EFSA panel highlights hens, egg, and peanut, and talks around those at the time of complementary food introduction. Now, if we go to allergy-specific guidelines, the APAPARI guidelines divides the advice given for allergen introduction in low risk and so at risk and high risk. So at risk, no delay introduction of allergens. And I think very sensibly to introduce it in a sensible manner once complementary foods have been introduced. The higher risk infants, however, they divide that in 2 categories: access to allergy expertise and allergy testing to egg, whether that's accessible or not. So they want patients to be tested if they have got access to allergy expertise, and in countries where there's high prevalence of peanut allergy, to test for that as well. If there's no access to allergy expertise, a supervised oral challenge to egg plus minor peanut is recommended. One can argue on the practicality of that, but that's the guideline from the Asia Pacific. The American Academy talks about that there's no evidence of delaying beyond 4 to 6 months, and highlights peanut, eggs, fish in particular, and then highlights also the advice around peanuts following the expert panel guidelines, which I'll talk about in a minute. The YACI guidelines, just to refresh your memory, from 2014 highlight no withholding or encouraging high allergenic foods. But again, these were published before the LEAP guidance came out. So I think we can agree that there is some overlap, that all of the guidelines in terms of allergy prevention guidelines as well as general guidelines talk about no evidence in regards to delaying beyond 6 months at least. Where there's differences is around the early introduction, in particular of peanut / egg. Now, what is the guideline or the expert opinion around peanut, which followed the LEAP study? And it indicates that healthcare professionals should recommend introducing peanut-containing products in the diet of high-risk infants early in life. And early in life is defined as between 4 and 11 months in countries. And I think that's important, where peanut allergy is prevalent, because for delaying could increase the risk of developing peanut allergy. Now, the risk defined by LEAP, which has also been taken up by these guidelines, was egg allergy, and the definition is very clear of egg allergy, and or eczema. So that's important to take into account when we think about these guidelines. What is also, I think, critical to think when we are considering children for allergy prevention is that we're not only thinking about prevention, but we're thinking about the nutrition per se. And this is where the strength of the general population guidelines really comes. Because if you look at doesn't matter, EFSA, WHO, American guidelines, Espigen guidelines, they all cover the nutrient requirements. So when is breast milk not sufficient? When do you require more energy? They also cover vitamin D, iodine, vitamin A, iron. And they would also cover, for example, the progression of introduction, variety of foods, taste, texture, salt and sugar content of foods. Now, this is something where your allergy prevention guidelines actually are not specific about. They may cover vitamin D, for example, or maybe omega-3 in regards to allergy prevention per se, but not general nutritional adequacy. And they certainly do not cover sugar and salt and progression of foods and texture, for example, in terms of oral motor skills. So for me, where these guidelines meet actually depends on a lot of factors. And I think this publication from my colleagues at Imperial College really highlights it very well. So when we're thinking about which guideline we use and also the guidelines provided to the individual, it depends on the population. It depends on if it's an at-risk population. It depends if you're giving the advice to the individual, because if I provide today guidelines for a general pediatric population, it's different to when I just talk to allergists or pediatric allergy dietitians, for example, who work with a higher risk population. In addition to that, we need to think about the prevalence of allergies per se. The advice that we give needs to, where the benefit needs to outweigh the harm. We need to think about the resources, acceptability and feasibility, all of those. So if we're thinking, therefore, of providing the advice, because that's really important, taking the guidelines that we've got and saying, okay, where do they meet and how do I make it practical? For me, the infant, the individual is at the heart of this. So, and firstly, we need to think about the nutritional requirements. And I think that's where our general guidelines are really good around breastfeeding, bottle feeding. And then we need to think about the risk for that specific child, but not only the risk of allergy. Our role working in pediatrics is not only thinking about that, but thinking about long-term health and the evidence for the nutritional advice for other reasons. And that's where the general guidelines are really good to support that around iron, around not gaining too fast weight, and also prevention of feeding difficulties. Then we need to think about the environment. So the advice we give around prevention needs to be meeting the socioeconomic class of the patients, the cultural religious requirements, resources, and also we think about the country-specific guidelines. The advice that I'm going to give to that individual in the UK versus my home country in South Africa is going to be different. Finally, once you've taken all of this into account, you need to be thinking about how to practically support the parents. So what advice am I going to give around breastfeeding, bottle feeding, the advice on when to introduce solid foods for that child, how to introduce this, how to expand the textures, and when and how to introduce the allergens. Because that's really important, is that the advice, for example, around peanut introduction needs to be made practical for how you can do it at home. So I'm going to conclude my part of this wonderful symposium by saying we of course want to support breastfeeding. Solid food is complementary to that. So guidelines differ on when to start complementary food. And there are some differences in language in regards to general versus allergy prevention. All of them based on good research. There is certainly consensus, and that's where the guidelines are meeting, on not delaying allergens. There's difference in advice on early peanut introduction between your allergy-specific and general guidelines, but I think that's where your skills as a clinician comes in to tailor it towards that individual, where you decide whether this child is at risk, and of course thinking about the resources. Then we need to think about the nutrient requirements and oral motor skills, which are often not covered by your allergy prevention guidelines, and then also think where these guidelines meet in regards to other information. Finally, but most importantly, I think it's really important to make the advice that we discussed today practical towards that individual. I'd like to end here and thank you for your attention.
Thank you so much for inviting me here to speak. I will be talking today about Around the World in 20 Minutes, Making Sense of Allergy Prevention Guidelines. I have these disclosures, but there are no conflicts of interest at the current time with my talk. The agenda today will be to first highlight the global prevalence of food allergy, then to discuss the mechanism behind tolerance, and then importantly to explore international food introduction guidelines, and then to review the evidence of the prevention of food allergy in terms of primary prevention, early and late food introduction, avoidance and extended prevention, multiple food allergy approach, and gaps in evidence and food future research. In terms of the prevalence of food allergy around the world, it's really important to note that this is increasing. We're getting more and more data every year. And importantly is that those countries that are in gray don't necessarily mean that they don't have food allergies, just that the data is currently unavailable. But as we get better at diagnosing food allergies and at using the same definition throughout the globe, I think that we will probably see between yellows and dark red in many of those other countries. As I travel around the world, I also ask many people about food allergies, and they are increasing, unfortunately, throughout the world. In some countries more than others. You can see Italy and Australia have some of the highest prevalence in the world. Now, before we start to talk about tolerance, I want to explain a little bit more about what tolerance means. It means that your immune system doesn't have any activation to either self or, when it comes to foods, things that we should be seeing as nutritious, that we don't see them as foreign and unfortunately get activated against them. But when we talk about tolerance and over time to try to gain tolerance to foods or other items, that oftentimes comes with changing immune cells, and part of changing immune cells relies on changing DNA, and that's through epigenetics. So when you think about changing DNA, that means that you're studying the changes in the gene function that are heritable and do not change the DNA sequence itself. And these mechanisms are controlled by DNA modifications, chromatin structure, histone modifications, nucleosome positioning, chromosome structure, and RNA modifications as well, microRNA and link RNA. This theme of epigenetics is rapidly growing, especially in allergic diseases, because a lot of the diseases that we face, either in nutrition and gastroenterological diseases as well as allergies, it seems to be both genetic as well as environmental. And then it's really important to understand that many of the diseases that we are dealing with in this age are multifactorials, that lifestyle, environment, as well as genes play a role in their etiology. Maternal atopy, for example, is very important. It can be epigenetically programmed, and it can be increasing the risk of allergic diseases in the progeny of the moms. Epigenetic modifications are sensitive to environmental exposure and thus represent a major mechanism underpinning environmentally mediated changes in gene expression, especially in allergy. There are some immune genes, like the HLA genes, that are associated with the development of food allergy, and there are some biomarkers that we've now done to use epigenetics to be able to tell who might have a food allergy and who might not. Other major aspects of making sure that our gut becomes tolerant and healthy is now being studied with microbiota research. Not just bacteria, but also viruses and fungi play a role. And importantly, there is data now, and this is a paper by Kim et al., showing that microbiota, especially Bifidus longum, could perhaps improve and decrease the likelihood of mast cells, an effector allergy cell, to be regulated and therefore decrease the likelihood of allergies. So again, this is an example in which microbiota specifically can be modified to help food allergies. And this is an example of a summary for which we have data so far showing that similar bacteria, Bacteroides, Bifidobacteria, Enterococci, seem to play a role in increasing the risk of asthma or decreasing the risk of allergic rhinitis. And you can see here that there are many pieces of evidence showing that microbiota play a role, but we're not too sure as to exactly which ones in particular might decrease the risk of allergies and asthma. But it's important that we keep this in mind as we think about a healthy gut in infants as well as people that are moving forward from infancy to childhood, to adolescence to adulthood. In going back to before infancy into pregnancy, there is much data now that thankfully Dr. Venter, who is overseeing this conference and one of the moderators, has published on the maternal dietary intake in pregnancy and lactation. And so when you look at conceptions and you think about the great nutritious modeling that many mothers have in terms of helping themselves be well nourished as well as their children, specific whole foods, diversity of diet helps in terms of decreasing the risk of overall patterns of allergy in the baby at birth and then during infancy. It's very important that during breastfeeding there is some relative protection against allergies, although that's not been proven exactly. But I think importantly is that during this process, breastfeeding is instrumental in maintaining good gut health. To summarize that, exclusive breastfeeding for at least 3 to 4 months in early infancy decreases the cumulative risk of atopic dermatitis. And that's really important for us to consider as we think about the immunomodulatory effects of breast milk. And that protection could be because of the gut microbiome and because of direct effect on the immune system, in addition to high levels of human milk immune factors like IgA, cytokines, oligosaccharides are important to reduce the risk of food allergy in the infant. Now I'd like to talk a little bit more about how we could potentially prevent food allergies once the infant is born. What kind of diets could we potentially help our children develop so that we can ensure that overall their guts and their immune system becomes tolerant to foods? In this instance, this study was done for peanut allergy. They looked at infants that already had evidence or no evidence of peanut allergy. So those children were moved into 2 cohorts, one that had a skin prick test to peanut of 1 to 4 millimeters, the other that had a skin prick test of 0 millimeters. And importantly, they split half of each of these groups into avoidance, i.e. what was typically suggested at the time of this particular study called the LEAP study, where children would avoid and infants would avoid any food allergens because it was thought at the time that by avoiding, you could perhaps decrease your risk of food allergies. But on the other side, another group in a 1-to-1 randomization were told to eat peanut about 6 grams a week. And what was dramatic in this particular trial, both in those children that came in the study either with a predetermined skin prick test positivity to peanut or not, was that there was a highly significant reduction in their risk of peanut allergy after having consumed peanuts regularly. And this, I think, changed all of our mindsets when we previously were being told as physicians to tell infants and their mothers and their fathers to please avoid any type of food allergen early in life. Instead, this showed us that we should probably be sharing information with families about diversifying the diet early and often and regular eating of foods, particularly peanut and other foods that we will talk about, to be able to prevent the risk of those food allergies later in life. And this was particularly important for those children that already had eczema, for those children that were born in families at high risk. And it also worked for those children that did not have high risk or did not have a familial history. So then, after doing that work, we also have, importantly, the LEAP ON study, in which those children avoided peanut for 1 year. And what we saw there was that there was a persistence of the same groups and their efficacy. This is a analysis and a meta-analysis that was done across many different studies that were using food allergy in a strategy for prevention, for egg allergy, for peanut allergy, or for milk allergy. And it was really important to show that for all of the studies, there was a decreased risk of food allergy. So it really didn't depend on whether or not it was peanut or egg or milk, but that there was this proclivity of once giving those foods early and often to the children in these studies, they were able to show a reduced risk. And then the timing of introduction at the first year of life also seems to be important. So a study called the Child Study that was done through Canada showed very important data, and I'll just show it to you here with my arrow, that the reduced risk of feeding early is shown here, that by feeding it within 6 months, for example, of cow's milk, you're able to reduce the risk of food allergies, and that continued in the same event for egg and then also for peanut. So it's very important to be able to know that by eating products early and often, and to decrease that risk of food allergy and to increase the risk of tolerance, we're seeing the data here in large meta-analyses as well as in separate cohorts done differently throughout the globe. This is another study in which the same group that had done the LEAP study also did work in multi-food introduction, so that if you were to give more than one food, for example, there was also a decreased rate of food allergy in those children that were able to eat 5 foods at once, for example. So again, by training the immune system, by training the gut, you see a decrease in risk of food allergy overall. This was very apparent in the per protocol population. Lastly, I'd like to talk to you about the evidence of a prospective epidemiological cohort called the Pasteur study that was done in Europe, and this was done throughout many countries in Europe. And overall, what this study showed, retrospectively looking at those children that were relatively protected against asthma, food allergy, and atopic dermatitis, is that upon diversifying their diet with an overall food diversity score that you see on the x-axis for these particular graphs, that reduced the risk of food allergy, asthma, and atopic dermatitis significantly. And when you look at the different measures of dietary diversity during infancy, this is a United Kingdom birth cohort, and you can see again the decreased risk of food allergy, over 96% reduction in food allergies over the first 10 years of life with the consumptions of 8 allergenic foods by 12 months of age. So the important imprinting period of the gut is happening of the immune system. 70% of your immune system is around the gut, and you can see here that by helping maintain that good gut health and maintaining dietary diversity early in life, you can try to prevent food allergies. And further, to understand the allergenic foods, now they're called allergenic not because the children that took them in this study actually were allergic, but these are the typical allergenic foods that are ranked highly among the global countries that have food allergies. And so for each additional allergenic food consumed of the 8, you can see the reduction changed over time in 6 months and then also at 12 months. And this is really important to understand, that we see this diversity of diet as a very important complement to what we need to do for normal gut health. Food diversity, but not the time of solid food introduction, reduces the risk of childhood atopic diseases. And this was found in a birth cohort from a developing Asian country, published in JACI. And you can see here solid food or allergenic food introduction, that you can still see a reduction at 6 months of age. And it seems to be also rigorously tested in many different countries, including this publication. Now I'd like to talk about some of the studies that we've done at Stanford, which was recently issued in a patent. And importantly, we looked at more than 8 foods being given at once in a healthy infant population, those with or without eczema. And we also enriched the population for a 50% increase in those patients that had a high risk for food allergy. So that means 1 first-degree relative with food allergy or atopic dermatitis, or 2 first-degree relatives with atopic disease. And the protocol was the following. We randomized into 18 groups, 25 per group. This was really a pilot study to get preliminary information. We had 9 single protein arms for prevention, 5 dual protein arms to see whether or not you might only need 2 proteins, for example, versus 3 multi-protein arms, i.e. 3 multi-food items. And we also had, importantly, different doses, because we wanted to understand to what degree did the food allergen introduction in the gut depend on the dose of the actual food. Because it's easier if infants can get less amount of foods per day rather than having to tell them to eat 3 grams of each food a day. That would be rather large and might not necessarily be convenient for the typical family. So we did a fixed 10 protein preparation of 30 milligrams per protein, 300 milligrams per protein, or 3 grams per protein. And then we also had a control arm that avoided the foods and received no diversity of diet complement. Infants were fed protein daily for a year, and this was indicated in milligrams per day of the associated food powder. And again, these proteins were each defined by the food allergen. And so what you see here is a graphic. The y-axis shows total protein per day in milligrams, and the x-axis shows the different groups that we ran the study in, control versus single protein versus double protein versus mixed. So at the mixed protein 1x, where each of the proteins was mixed 1 to 1 to 1 to 1 to 1, you can see here that the total was 300 milligrams or 30 milligrams per protein, and then we went higher to 100 milligrams per protein, and then higher to 3,000 milligrams per protein, or 3 grams. And what was really interesting to see is after 1 year of feeding, the IgE biomarkers were substantially decreased. What's important to know is the control group, unfortunately, had an increase in the IgE, whereas the single protein, as would have been predicted by the LEAP and the EAT studies, that was reduced, but the double protein wasn't significantly better. But when the mixture of proteins was given, either at 1x, 3x, or 10x, we did not see IgE at the detection of the assay. We also looked at biomarkers, for example, IgG4, that protect, relatively speaking, against the IgE-mediated allergies, and we saw that increase in the mixed protein amounts. So we followed that patented data with another large randomized controlled study called the I'm Eating study. And this was actually done after Stanford University licensed the patent to a company called Before Brands. And that company then sponsored this research through Northwestern, and our colleague, Dr. Jane Hall, performed the study. And Stanford was not involved, and neither was I. However, it is important to note that with this particular feeding regimen, the children were randomized, were either fed food supplement or placebo, and we had a good completion response of 88%, and we had a very good safety profile. No children had any food allergies that were developed during this protocol, and no one had any food allergic reactions during the protocol either. This was done after 28 days, and there was a subgroup that was followed over the long term, and that's important to know that of the long-term subgroup, no one developed food allergies or had any increased risk of reactions or adverse events. So in summary, there's still future research needed. I've summarized some critical data, and this is among many pieces of evidence that now is global that shows that prevention of food allergy is possible, and that eating a diverse diet is important for good gut health and prevention of food allergies, that there is moderate to high certainty for evidence in peanut, egg, and milk prevention. Low certainty evidence has now been provided for wheat, tree nuts, soy, finfish, and shellfish. We continue to run clinical trials, and that is critical to be able to understand the role of prevention and how the immune system changes over time to be able to have and afford an improved quality of life and overall health. Thank you.
Hello, my name is Karina Venti. I'm an allergy specialist dietitian from Denver, Colorado. Today we will be discussing It's All About Diversity, foods, food groups, and food allergens. Please take a note of my disclosures. So the objectives of my presentation today are to be able to define diet indices and diet diversity, be able to give practical information regarding implementing diet indices and diet diversity for food allergy prevention, and discuss the possible mechanisms by which diet diversity may prevent allergic outcomes. So let's discuss definitions first. Diet diversity, or diet variety as some people refer to it, can be defined as the number of different foods or food groups consumed over a given reference period. It could also be, in our world of food allergy, the number of food allergens consumed over a given reference period. Diet quality has no official definition in the literature. Definitions vary widely, and many different measurement tools are used. But in essence, diet quality is normally used to reflect the nutrient adequacy of the diet. It may not always be the case, but that is the main reason why it's being used. And diet quality is often described using a diet index, such as the Mediterranean Diet Index. So diet diversity. The European Academy of Allergy and Clinical Immunology brought a task force together to look at what does diet diversity mean in relation to allergy outcomes. This task force was spearheaded by myself and Dr. Liam O'Mahony. And after the systematic review of the literature, we came to the conclusion that there are no studies looking at diet indices or the use of diet indices during pregnancy and allergy outcomes in the offspring. There were also no data on diet indices during breastfeeding and offspring allergy outcomes. We were only able to find one study by Caroline Rudet looking at diet diversity in the first year of life versus food allergy outcomes later on in childhood. And this group reported that an increased diet diversity in the first year of life was associated with reduced food allergy outcomes up to 6 years of age. Since the publication of the IACI report, I published my own data from the Isle of Wight, looking at 4 different measures of diet diversity in the first year of life and how that relates to food allergy outcomes by 10 years of age. The 2 most important outcomes which I will be reporting to you today is the number of food allergens introduced over the first year of life and the number of foods introduced over the first 9 months of life. And as you can see from this slide, as the number of foods introduced by 6 months of age increased, the likelihood of developing food allergy over the first 10 years of life reduced. Also, strikingly, as the number of allergenic foods introduced over the first 12 months of life increased, so did the probability of developing food allergies over the first 10 years of life came down. The next slide summarizes it a little bit better, I think. And we've shown in this study that for each additional food given by 6 months of age, so the babies were weaned early, for every additional food given by 6 months of age, the likelihood or the odds of developing food allergy over the first 10 years of life came down with 11%. Also, for each additional food allergen given by 12 months of age, there was a significant reduction of 33% in the likelihood of developing food allergy over the first 10 years of life. It's important that we should see this data in context. This is an observational study. It was not an RCT, but I think the message is clear. Let the babies eat. We shouldn't wait with introduction of foods when they are developmentally ready to eat, and we shouldn't wait with introduction of food allergens. It's safe to give during the first year of life. But of course, as we increase allergen diversity, it also poses practical problems to us and to parents. When we published the NIAID guidelines in the United States, alongside the guidelines, we also published practical handouts for parents, which you can access from the link at the bottom of the slide. We gave 4 recipe options for the introduction of peanut by using either Bamba snack, smooth thin peanut butter, smooth peanut butter puree, or peanut flour and peanut butter. But despite the practical written handouts that are available to parents, parents are still concerned about introducing peanut, especially if another family member, such as another child, have a peanut allergy. Parents say the infant sometimes dislike the peanut taste and texture, and parents are also concerned about the implications of the infant not eating the whole dose or missing a dose because they are sick. We have even more questions about the practical implementation of early introduction of egg. We're really confused about which type of egg should be given. Should it be cooked, baked, boiled, pasteurized, or raw? As the RCTs performed of early introduction of egg use different forms of egg. The dose of egg is not clear. Some studies used as low as 1/100th of an egg, depending on the size of egg, and some studies use up to 1/3 of an egg 2 to 3 times a week. It's very difficult to find infant-friendly heated options of egg. Nobody really wants to give 4-month-old infants cookies and cake and muffins and cupcakes containing baked or heated egg on a regular basis. And my practical experience is that infants often do not like the taste of hard-boiled egg. They also do not like the texture. And practically, we often end up pureeing or liquidizing the boiled egg and mixing it in with a favorite food, such as a yogurt or a fruit puree. We're also concerned about the implications on nutritional intake and growth when we introduce allergens early. But we had very reassuring information from the LEAP study showing that there was no difference in growth indices in the active arm consuming peanut versus the control arm avoiding peanut. There was, however, a difference in the fat and carbohydrate intake between the 2 groups, with the peanut consumption group eating more fat and the peanut avoidance food eating more carbohydrates. This may have some nutritional implications, as I will show you on the next slide. On this slide, I've compared the calories, fat, protein, and iron content of 15 gram or half an ounce of beef to chicken to Brazil nut and walnut. And as you can see from this slide, the nuts are significantly higher in calories, significantly higher in fat. They contain slightly less protein, and the iron content of the 4 foods may appear to be similar, but in my practical experience, it is more likely that the infant would eat a larger portion of lean beef or chicken than they would eat when they eat nut butters. So this slide really is not to say we should not be giving allergens because they're high in fat and it's not good for babies. Infants do need a higher fat diet than what we would recommend for adults. So it's not a major concern, but it is important to be mindful of the fact that nuts do contain high amounts of calories, but mainly coming from fat, and that we do not want to overconsume any particular food in the diet, even as we are trying to increase intake of allergens such as tree nuts. It's very difficult to know how much wheat, milk, sesame, soy, fish, and shellfish should be given for allergen prevention. And even if we look at the healthy eating guidelines, it's still not clear how often many of these allergens should be consumed on a weekly basis, even just for healthy eating purposes. We know for wheat we have portion sizes, daily consumption is recommended. For milk we have portion sizes with daily consumption recommended. We have portion sizes for sesame, soy, tree nuts, but we do not know in terms of healthy eating practices, how often these foods should be consumed. And we just do not have the allergy prevention studies to give us very clear guidance on how often these allergens should be consumed for prevention. Fish and shellfish intake, we do have sort of like guidance or estimates of portion sizes, but the frequency of consumption will really differ between countries depending on local guidance. And the main problem with regular fish consumption is the concern about the mercury content of the larger fatty fish species. So it is important to be aware of how often fish consumption is recommended in each country. Then moving on to diet indices. There is, opposite to what we've seen with diet diversity, we do have data on use of diet indices in pregnancy versus offspring allergy outcomes, but we once again have no data for lactation or breastfeeding women, and we have no data about the use of diet indices in infancy and allergy outcomes in later childhood. So I'm going to briefly go through the 3 diet indices of which we have data on allergy prevention. The first one is the Mediterranean Diet Index. For the sake of time, I'm not going to take you through every single step of the Mediterranean Diet Index, but we all know that the Mediterranean diet is characterized by frequent intake of olives, fruit and vegetables, or olive oil for that matter as well. So when we look at this, the studies comparing the Mediterranean Diet Index in pregnancy and offspring allergy outcomes, very disappointingly, we found that only one study saw a significant preventative effect, and these authors looked at persistent wheeze, atopic wheeze, and atopy. The next diet index that was used to look at the association with allergy outcomes is the Healthy Eating Index. There are 3 different forms of the Healthy Eating Index, but what I have done here for you is highlighted the nutritional factors that actually get a positive or a negative score in the Healthy Eating Index, but which has never been associated with allergy outcomes, such as sodium intake, for example. There are some studies looking at folate intake versus allergy outcomes, but as we all know, folate has got its own sad story when compared to allergy outcomes. So again, that may muddle up with what we see when we compare the Healthy Eating Index to allergy outcomes in the infant. And so the 2 studies that have looked at allergy outcomes in the infant, one from the US and one from the UK, both showed that there was no association between healthy eating in pregnancy using the Healthy Eating Index versus the very different forms of allergy outcomes in the infant. And we did actually look at the range of outcomes such as wheeze, atopy, and allergic sensitization. The third index that was used to look at allergy outcomes in the infant is the Inflammatory Diet Index. You can see that this is a very complex diet index with many different positive and negative scores given to food. For example, garlic and omega-3 fatty acids get a positive score, whereas omega-6 fatty acids get a negative score alongside trans fatty acid intake. At present, we again have only 2 studies looking at this diet index versus allergy in the infant. And the study from Ireland shows that they did find an association between a pro-inflammatory diet. So as the diet became more pro-inflammatory, so did they see more offspring asthma. The study from the US, however, found no association between pro-inflammatory diet scores and asthma outcomes. So we find contradicting data with the asthma, but the study did, however, the one from the US, found an association between the diet inflammatory index and offspring wheeze trajectories up to 7.5 years of age. So then we think, well, how would diet diversity affect allergy outcomes? What is the mechanism behind diet diversity? And at this point in time, we don't have really clear data, but we do think that diet diversity may be affecting offspring allergy outcomes via its effect on the microbiome. And if we consider increased food intake over the first year of life as an increase of diet diversity, then you can clearly see that as the number of family foods increase, so does microbial diversity increase using the Shannon index. The same is true for fiber. As fiber intake over the first year of life increase, so does microbial diversity. And as protein intake increase over the first year of life, so does microbial diversity. Getting back to what I showed you about the high fat content of nuts, it's interesting to see that as fat intake increased over the first year of life, microbial diversity came down. So perhaps just something else to take into account when we do introduce tree nuts on a regular basis. We do want it in the diet, we want the allergens in the diet, but we don't want to overconsume a very high fat food in infancy, particularly if it may replace important nutrients such as iron and perhaps calcium-rich food, but these studies need to be conducted. Then the last slide that I want to share with you is, again, data from Caroline Roudet's group. So perhaps this study is not strictly speaking a study on diet diversity, but the authors did show that as diversity of yogurt, fish, and fruit and vegetables increased in the first year of life, so did the butyrate production by the infant's microbiome. And as we all know, as butyrate production increase, so does the effect on the T regulatory cells. So we get upregulation of the T regulatory cells, and then we see reduced outcomes of allergy outcomes. And we've already showed you that in this study, increased diet diversity in infancy was associated with reduced food allergy. And so this is why at this point in time, we do think that increased diet diversity may have an effect on reduced food allergy outcomes via its effect on the infant microbiome and increased butyrate production. So just to summarize, in terms of diet diversity in pregnancy and food allergy in early life and diet indices in infancy and food allergy in early life, we have no data. The best data we have is diet diversity in infancy versus reduced food allergy outcomes. And even though different definitions were used in the studies for diet diversity, the data does look promising. In terms of diet indices or patterns in pregnancy and allergy outcomes, we think it may affect WEAS trajectories up to 7.5 years of age based on one study, but the data on asthma is contradictory. And then diet diversity or diet indices in pregnancy versus infant allergy, infant microbiome, we have a lack of data. There's no clear data, but as I've showed you, if we assume that increased food intake in the first year of life is a reflection of diet diversity in the first year of life, then its effect on the microbiome may explain why we see reduced food allergy outcomes in the infants. So I would like to thank you for your time, and I thank you for all my collaborators across the world, and I look forward to further discussions during the question and answer sessions.
Go.
Hello, and as you've already heard, my name is Karina Venti, and I'm joined today here by Dr. Karina Venti and Dr. Roseanne Meyer. I hope you've enjoyed our presentation, and we're now into the live question and answer session. So for some of us, it's very early morning. For some of us, it's right in the middle of the night, but we're very happy to be here. We've had a number of questions. We've got about 12 minutes, just perhaps over 15 minutes to address these, to be honest, 17 minutes. And so I'm going to start with the first question to Dr. Roseanne Meyer. Is there a definite time when to start introducing gluten?
Thank you, Karina. That's an excellent question. And I think there's been a lot of confusion because, of course, we have the studies based on celiac disease and diabetes, a lot of them coming from Sweden, the Nordic countries. And if you look at the data, some of them is quite conflicting. as I've already presented today on guideline, I'm the guideline person. Epigenetics recommends to introduce between 4 and 7 months, but whilst breastfeeding, but that's specifically for celiac disease. And the question today is about allergy prevention. So from an allergy prevention perspective, what I normally recommend based on the data that we've got to start when complementary food is started. And we already had such amazing data presented. And I think part of it is making that practical, and thinking about that practically is thinking when you're introducing fruit, vegetables, and then your gluten comes almost automatically when your oral motor skills are there. So I think my message would be for allergy prevention, start when complementary foods are commenced.
Thank you, Dr. Meyer. So the next question I'm happy to take. Is there a risk of taking too much vitamin D during pregnancy and early life in terms of allergy prevention? I think this is a very relevant question, particularly in the COVID times, because we find that everybody is jumping on the vitamin D bandwagon. But like everything else in life, moderation is the key. When we look particularly at vitamin D supplementation in pregnancy, and our systematic review as an IACI task force report have just been accepted in pediatric allergy and immunology, but it's not out yet. But our systematic review shows that vitamin D supplementation in pregnancy at best may prevent wheeze or asthma. The caveat or the caution, however, is that when vitamin D is taken in dosages higher than recommended, for example, by the EFSA or in the United States by the IOM, there's an increased risk of food allergy, particularly high dose intake during lactation and early life. So I think the question is, vitamin D is an important nutrient, but important to stick to national guidelines opposed to just over supplementing in the hope of preventing any disease for that matter, because you may inadvertently increase the risk. So then the next question I'm going to give to Dr. Karina Nadeau. Nobody better than Dr. Nadeau to answer this question with a wealth of research in this field. What is the optimal amount of food protein or food allergen to start with when you introduce complementary feeding?
Thank you so much. It's a pleasure to be here today, and welcome to everyone in this international conference. So we're so excited that we're here, and I want to say thank you again to Nestlé and to Rosen and to Karina for being able to be part of this team that we're talking to you today about. I think that's an excellent question. We really need to make sure that we understand the science, that the science has to tell us what is the best dose to give to a baby, to an infant, and what is easy to give. And we want to also make sure it's safe. So what we don't want to do is give children foods or protein amounts that could lead to any allergy or could lead to any effect that we don't want. And so what we've done is to study, at least for the data that we have now, we know that a small amount is only needed to be able to diversify the diet, because we want to have the baby have their gut be educated. And so only a small amount of about tens of milligrams are most likely what we have found to be needed to be able to prevent food allergy for the long term. And that's good to know, because too much, as you're hearing from Karina as well as Rosen, might actually be deleterious. And so we have to be very careful, but we have to use our science to help us know what the right dose is, what the right serving size is. And for that we know so far that we've published, it looks like it's about tens of milligrams, about 30 milligrams of each food right now seems to be a good sweet spot that we can know will not induce food allergies, but also will not hurt the gut of any infant. But we're still learning, and we're still learning in different ages, and that's so far that we know to be helpful. Thank you.
Thank you. So thank you very much to the next question. This is the kind of questions that we as allergy dietitians love to answer, and I'm very happy to hand this question over to Dr. Meyer. So the question is, can we conclude that when switching to complementary feeding, we should start with several foods at the same time, not one by one?
This is an excellent question. And I think firstly, we have to remind ourselves, what are we trying to achieve? So We're not talking about here a child that is allergic, we're trying to prevent. So from the data that's been published, and as Dr. Nadia already says, we need to be guided by the science, but need to make it practical. But from what has been published, actually what you want to do is get as many and get them in combinations in. So if I practically advise, I certainly don't go one food and then try it for 3 days or 4 days, or even worst case scenario, 5 days, because you'd actually get such a low dietary diversity, which is not only possibly have a detrimental effect in regards to allergy prevention in future or the microbiome, but actually we need to be thinking about oral motor skills and also the exposure to different textures and tastes. So I would say that very practically you would introduce them together, and in mixtures it's also to get different flavors together in rather than single flavors as well.
Thank you, Roseanne, for that. So the next question is sort of like along that line, and I'm happy to answer that one. What about children with a current food allergy? Can diet diversity prevent future food allergies? Well, again, we don't have the direct data, but possibly, and it makes sense that if you know a diverse diet in early life prevent food allergy later on, that even in a child with one food allergy, focusing on a diverse diet may prevent future food allergies. And again, I think this highlights the important role of the allergy specialist dietitian, because the minute somebody becomes allergic to a food, we actually hit their diet diversity in a negative way, because we're telling them or advising them to cut foods or certain food groups out of their diet. And the example that I often use is when I have children with food protein-induced enterocolitis syndrome or FPIES, often the diet is very limited, but I do say to mothers that every food we introduce in the diet counts, as Dr. Nadeau showed and I showed in my presentation. With each additional food introduced in the first year of life, the risk of developing food allergy come down. So this is where dietitians play a key role to try and get the diet as diverse as possible within the limitation or this restriction of current food allergies. So, so I would definitely say yes on that one, with the caveat that we definitely need more studies looking into diet diversity in those with current food allergies. So on that topic, I'm going to skip one of the questions. I'll come back to that, but I want to ask Dr. Nadeau, how do you conveniently diversify the diet?
Yeah, it's an excellent question, and I think a lot of parents ask this. I'm a pediatrician, and I always like to work as a team with our dietitians and our nutritionists, because each family is a little bit different. And I think each family has different cultures, but importantly is we want to be able to present something that's easy, that's convenient, that once you start to help a diverse diet, once you start to have good eating habits, you want to also make sure those are sustained, that it's not just the first day. You want to make sure it's regular patterns, and like everything in moderation, how do we make sure that something is fun and easy? So we're excited that we have a easy to use product now that has the 16 food proteins in it that represent 16 food allergens, to be able to diversify the diet easy in one place, in one unit, in one spoonful. But importantly is, how do you make that fun to be able to provide something easy to use for parents that could be provided to the child throughout their first year of life? We know that that's a very important time interval. So I think it's possible. I think there needs to be creative and team-oriented ways to help the families. And in that regard, it takes a team effort, pediatricians, clinicians, parents, really working to make this important for the child's future, and that it's based on nutrition and good eating habits. But it is possible to do it conveniently in small amounts and with fun items that the child can eat without a lot of sugar and without a lot of items that could be something that's not nutritious. So there are now products out there. I'm really excited about the new ways to prevent.
Thank you for that. So I'm going to give two questions now to Dr. Meyer. And the first one is, Do you think it is important for guidelines to match in regards when to start introducing complementary foods and potential food allergens?
Dr. Venti, that's an excellent question, and thank you for posing that question. I think here, if we're thinking about the different countries, the research that comes from different countries, the differences in availability of foods, food security, religious and cultural acceptance, I think it will be very difficult practically for all different countries to match in regards to their guidelines exactly. And I hope I've demonstrated that already. I don't think any of the guidelines that I presented with the language between 4 and 6 months, around 6 months, at 6 months, was meant to be, all of them are based on really good research. So my answer would say, I don't think it's important that they match exactly, because guidelines are meant to actually support through evidence a specific community. I think what is important where guidelines should be matching would be in regards to the support for breastfeeding. But outside of that, I think guidelines very much, as I hope I've demonstrated with my presentation today, we need to be mindful of the population for whom it's meant to, and for the research that has come out of that population. So I think, therefore, there will always be some variation within guidelines. It's impossible that what fits for one country is definitely correct for another country.
Thank you, Dr. Meyer. And then, do you think that early introduction of allergens increase the nutritional risk of the diet?
Excellent question as well. So that one really, if you look at the EFSA document that was published, they actually had one of their primary outcomes was to look whether early introduction poses a risk, and they didn't find a nutritional risk. In fact, they actually reminded us that for example, in mothers that have iron deficiency anemia, intrauterine growth retardation or preterm can be of benefit with the introduction of iron-rich foods. I want to say that in line with what each one of us has said, everything comes with a caveat. Early introduction also needs to take into account nutritional needs. So if we're introduced, we need to also think, and that's again of why we want to be working with dietitians, is to think, okay, anything excessive, too much of one nutrient versus too little of another one. So early introduction in the right hands, I would say to you, does not pose a risk of any nutritional deficiencies.
Thank you. That really clarifies it. So the next question is going to go to Dr. Nadeau, and lovely to know that Monse Alvaro is attending our session, and she's got a question. No surprise with her Spanish background. In an infant with cow's milk allergy or atopic eczema, when do you introduce fish? And what kind of fish first? Do you test before the fish? And same applies to eggs. So tough question, Dr. Nadeau, but I'm sure you can handle it.
Well, I will try my best. You know, we're only as good as our data and our science. So these are all great questions, and I'm so happy. And feel free, Dr. Venter and Dr. Meyer, to also chime in. But I think for now that we know, as long as we have understood the child and the family, and if there's not already an allergy to fish or egg, that it is okay to start to introduce those proteins in small amount. And again, let the science dictate. So to me, I would want to make sure that we have a fin fish, either with white, with cod, and also salmon, so that we can make sure that the parvalbumin and different protein structures are accessed to the diet, but in small amounts. You don't need to overdo it. And that includes also egg proteins as well, safely, with no risk of salmonella. And I think that's possible. I think that my colleagues, Dr. Meyer and Dr. Venter, have published ways to be able to do that. We've certainly also published that through our work at Stanford. So it is important to ask these questions. That's critical. And I think for cow's milk allergy, we need to really understand the timing of introduction as well. But all that we're saying right here is very complementary and very synergistic with the WHO guidelines. We want to promote breastfeeding. We want to promote the WHO guidelines and make sure that none of what we're saying today is at the exclusion of breastfeeding or really good habits that are consistent with the WHO guidelines as well. So thank you.
Thank you for that. So we have 1 minute, and I'm going to try and answer 2 questions in one go. So the one question is whether C-section increased our risk of allergy, and then the next question is whether we should feed the gut certain foods to produce gut microbial diversity. And I do think the two goes hand in hand, because I'm not convinced that C-section increased the risk of allergy. You cannot give somebody a C-section without using antibiotics. So we really need to tease out whether it's the C-section and the lack of vaginal delivery, or whether it is the use of antibiotics, which will of course destroy our gut microbiome diversity in both the mother and the infant. So that's that. And then I think, you know, what you're asking is, do we have a specific diet mix that's going to best increase diet diversity and butyrate production? And I think many of us are smiling. We all have collaborators looking at that. Some of us are putting grants in, doing research as well. And yes, I do think that there is perhaps a diet that we really want to advise to definitely produce butyrate production in the gut through a more diverse gut microbiome. But what exactly that diet should look like at this point in time, I don't think we are clear. But hopefully in a year from now, I'll have the answer from either my own or other people's very interesting work. So it's 15:15. I want to say it's 2:15 a.m. here with me. Wherever you are in the world, it's 15 minutes past the hour, which means we have to wrap this up. Thank you so very much for attending. Thank you to my co-speakers, and thank you for all your very interesting questions. And have a good day, as the Americans would say.
Thank you from my side as well. Thank you, Karina and Clary.
Thank you.
Bye-bye, everybody.